next one will be held in the first half of September. And I want to thank also MCA for the perfect organization of the webinars. Now I leave the floor to Virgilio Carnielli to introduce the speakers. Of course, I am grateful to all of them for their precious collaboration. Thank you. Please, Virgilio.
Thank you, Corrado. It's a pleasure. Dear colleagues, it's a pleasure to be here today for the third day of module two that is entitled What's New in Parental Nutrition for the Newborn Infant. Today, June the 23rd, we have the third day, as I said, and we have two excellent speakers. We have Professor Jacques Rigo and Professor Jeffrey Segar, and we'll have a talk on calcium, phosphorus, and bone health, and on electrolytes and water. There will be two 20-minute talk, and at the end, we'll have a short 20-minute discussion where we try to accommodate the questions that you may pose or you may send us during the two presentations. And we will try to have a bit of a roundtable, or we discuss what is new in parental nutrition. And then we'll close up. Well, I have the privilege now to introduce Professor Jacques Rigo. Jacques is a friend, and he is a past professor of neonatology and pediatric nutrition at the University of Liège in Belgium. Jacques was the designer of the amino acid solution called Primine and of the standard PN solution preparation, Numeta, produced nowadays by Baxter. And today's presentation of Jacques Rigo is entitled Calcium, Phosphorus, and Bone Health. Jacques, please, the microphone is yours.
Did you see my presentation now?
You have to upload, probably.
I don't know.
You go to share screen.
Yes.
Professor Rigo, this is Natalia speaking from MCA.
I think that I need to écran partagé.
So the first thing, you should open your presentation on your computer, the PowerPoint presentation.
Yes.
And then on Zoom, you see at the bottom of your Zoom screen, you see the green button that says "Share the screen." It can be also in your language if you're using.
Share.
The green folder, Jacques.
Yes.
Yeah. So
with
you
the
click.
arrow up.
Yeah. So you click on that, and then there is a pop-up window. Did you click on the green button? Yes, perfect. Okay, and just put it in the presentation in slideshow mode.
Yes.
Perfect.
Yes.
You go to the presentation mode.
Okay.
Fantastic.
Okay,
We see it. Thank you.
Thank you.
And so, first of all, I want to thank Virgilio and the organizing committee for inviting me to discuss about a topic that I like very much, and which is now still controversial, even in the Afghan Committee of Nutrition. And so we will try to discuss about the mineralization and bone health in the preterm infants, and with a specific view on parenteral nutrition. In this presentation, we will discuss about the mineral requirement in the preterm infants. As you know, from many years, the fetal accretion was taken into consideration for define the mineral requirement in the preterm infants. But more recently, there is some suggestion that the postnatal mineral metabolism of the preterm infants differ to that of the fetus, and that it could be possible to be more oriented about the postnatal bone mineral metabolism instead of the fetal accretion, and I plan to discuss that with you. After that, we will see some specificity of the parenteral nutrition in terms of mineral survey and the postnatal survey of the mineral supplementation to the preterm and parenteral nutrition. So firstly, the fetal accretion was measured with different techniques, the carcass analysis, neutron activation, and dual X-ray absorptiometry. And what is relatively surprising that if we collect all the results, they are quite similar, and you see that there is a linear relationship between the bone mineral content or eventually the calcium content and the growth in the fetus. And so it is possible to define what is the fetal accretion of the calcium and the mineral, and you see that on this base, we can calculate that during the fetal life, the fetus accumulate approximately 120 milligrams of calcium per kilobody weight per day, or 70 milligrams of phosphorus, which could be defined in terms of millimole, 3 millimole of calcium and 2.3 millimole of phosphorus. So it was mainly this value, it was taken as reference for the preterm infants in oral or in parenteral nutrition. The first point that I want to underline is that the fetal phosphorus retention, in fact, the phosphorus need are probably higher than that derived from the mineralization of the body and from the calculation of the hydroxyapatite deposition in the bone. In the bone, the hydroxyapatite calcium phosphorus ratio of 2.1 in mass and 1.6 in as molar ratio. But the newborn infants also, as the fetus, need additional phosphorus intake where requests for energy metabolism and the cellular growth. And we know, and you know, that phosphorus and potassium are the major intracellular cations. And there is a turnover of the phosphorus during the fetal life. And so this part of the phosphorus need is not completely taken into account when you look only the carcass analysis and the fetal retention. With metabolic balance study, we showed that an additional phosphorus retention is needed in relation to the protein and the amino acid retention. And so calculate that about 11 milligrams or 0.3 millimole are necessary for each gram of protein or amino acid retention. And in addition, when we look to metabolic balance in parenteral nutrition, but also in enteral nutrition, as I will show it later on, we see that the calcium phosphorus retention, the calcium phosphorus ratio of the retention is lower than that of the fetal estimate. So the calcium phosphorus ratio is lower than that in the hydroxyapatite. Just think that additional phosphorus is necessary for the preterm infants. So how is the mineralization of bone during the fetal life? The main factor for bone growth is the energy and the protein supply to the preterm infant. It will induce the bone matrix growth. After that, you need a mineralization. In fact, when we look at mineralization during the fetal life, we see that the modeling is largely predominant. So all the bone metabolism is oriented to make mineral deposition on the matrix, the growing matrix. the remodeling process is completely suppressed during the fetal life, due firstly to the relative high fetal calcium content. The fetus is relatively hypercalcemic. There is a PTH inhibition during the fetal life. The fetus is living in an estrogenic climate, and the fetus also has some more physical activity than the newborn in the neonatal intensive care. So I think that that is the drive for the bone metabolism and bone growth, because there is a strong calcium and mineral deposition during the fetal life. So we can summarize that due to the transplacental flux, we receive calcium and phosphorus that go in the plasma pool, and all is oriented to bone for growth and modeling. And what we observe is that we obtain a progressive increase in the volumetric bone mineral density during the fetal life. That can be shown using dual X-ray absorptiometry. Here, you see the result that we presented in 106 preterm infants, and we correlate the bone mineral density. It was an areal density as in DEXA according to gestational age, and you see that there is a sharp increase during the fetal life from 28 weeks to the time term. Similarly, if we calculate not only the bone areal density, but the true volumetric density, and for that you induce the bone area with a power 1.5, is allowed to evaluate the proportionality between the bone mineral content and bone growth. So it allowed to estimate if the bone mineral content increase is similar, higher or lower than the bone growth. So with such a calculation, we know if 1% of the bone volume increase, we need to obtain an increase in bone mineral content similar to of 1%. But in utero, you see that the BMC increase, the volumetric bone mineral density increase more than the growth of the area. And so there is a progressive increase in volumetric bone mineral density during the fetal life. In utero, the BMC increase is higher than the bone growth, and we have a progressive increase in density and mineralization of the bone. By contrast, after birth, there is a postnatal stimulation of the bone remodeling. Why? There is firstly, at the time of birth, an interruption of the high calcium and phosphorus supply. We use parenteral nutrition with relatively low calcium and phosphorus solubility. And when we provide enteral nutrition, you know that the calcium, the gastrointestinal absorption rate is relatively low. So we need quite high calcium to obtain calcium available for bone mineralization. As you know, there is a PTH surge, and frequently we are newborn infants and mother are vitamin D deficiency. There is low physical activity in the preterm infant in the NI unit, and the estrogenic environment of the mother is stopped at the time of birth. In addition, if we compare the bone of the fetus and the bone of the newborn infant, they need to improve their bone strength. And the remodeling process with increased calcium and phosphorus of the bone turnover. So I think that after birth, we receive calcium and phosphorus by parenteral supply or by the gastrointestinal route, but we receive also in the plasma pool some calcium and phosphorus coming from bone remodeling. And so the two need to provide the calcium and phosphorus preterm. What we have said is that the volumetric bone mineral density stays similar or decrease in the preterm infant. So the increase in the calcium and phosphorus turnover occurring at birth could reduce the nutritional need of the preterm infant. Here you see that just after birth, there is a decrease in the serum calcium concentration during the first day of life, and there is a surge of PTH. They come very quickly on the second day of life, first day of life, and stay high during the first part of life in the preterm infant, inducing reduction in the plasma calcium concentration and a reduction in the availability of calcium and mineralization. So the beginning of 2000, Rhodes and Chernow have published the adaptation of the bone to postnatal life. What we see, it is at birth, if we take longitudinal bone, we see that the cortical thickness is relatively high and the medullary thickness is small. What happened from birth to 6 months of life? You see that the cortical thickness remains about similar. There is a small decrease of 8% between the birth and 6 months in thickness of the cortical thickness. What is increased in is the medullary diameter. The cortical density does not change a lot. They stay about similar, less 7%. But if we calculate the areal bone mineral density, you see that the total density of this volume comparatively to this one is significantly decreased. It is what we observe with X-ray absorptiometry. By contrast, as bone grow, the mineral content continue to increase of about 60% during 6 months of life. However, what is relatively important is the development of the functionality of bone. And the bone strength increase about 3-fold because of the change in the bone geometry. So this evolution improves the bone strength, rigidity, and solidity of the bone of the preterm infant. It is possible to evaluate that point in clinical or with dual X-ray absorptiometry. So we present here the volumetric bone mineral density. It was evaluated in 126 preterm infants and 262 term infants in the preterm infant or from term to the end of the first year. What you see? It was preterm infants with dual X-ray absorptiometry during the first 3 days of life. 106. We see, as we showed previously, that the volumetric bone mineral density continued to increase progressively from 28 weeks up to the time of the term. After birth, in healthy term infants, we see that there is a decrease the volumetric bone mineral density during the first 2 or 3 months of life, and after that it is relatively stable up to the end of the first year of life. What happened in the preterm infant? In the preterm infant, they are at similar value that the fetus at the time of birth. And we observe also a similar decrease, probably due to the change in the metabolic rate of the bone during the first month of life. The remodeling stimulation occurs also in the preterm infant. So there is really a change in the bone metabolism in the preterm infants. After birth, he will conduct like the term infants during the first month of life. We observe both in preterm and term infants that the volumetric bone mineral density decrease similarly during the first week of life as a result of the remodeling stimulation. So now we are in parenteral nutrition. And what is the physiology of the calcium and the phosphorus provide in parenteral nutrition? In parenteral nutrition, we provide calcium, phosphorus, amino acid, energy. They are directly available for metabolism. The preterm infants as there is provided in intravenous manner. After that, the first point was the growth in lean body mass. In lean body mass, the nitrogen retention, and we have some phosphorus retention related to the protein retention. And I show you that it was close to 10 to 11 milligrams or 0.3 millimole per gram of protein. After that, the remaining calcium and phosphorus as available for bone mineralization with a ratio as hydroxyapatite from calcium and phosphorus ratio of 1.6 in millimole and 2.1 in mass. If there is sufficient of phosphorus for calcium deposition, or if there is phosphorus insufficiency, but the calcium cannot be deposited in the bone, and they will go to urinary excretion. And so, if you observe urinary excretion of calcium in the preterm infant, mainly it is related to a relative phosphorus deficiency in bone mineralization. By contrast, if you have a relative overload of phosphorus, you will not see any calcium in the urine, but mainly phosphaturia will be observed. So, with the control of the urine, you can decide how to manage the calcium and phosphorus relationship during parenteral nutrition in the preterm infants. And so you see the relationship between urinary excretion of calcium and urinary excretion of phosphorus in the preterm infant during metabolic balance study. You see that you obtain only relative high calcium excretion in case of low excretion of phosphorus. If you have a relatively higher excretion of phosphorus, you have very few calcium in the urine. So the calcium and the urinary calcium and phosphorus are very interrelated in the preterm. So what to provide during parenteral nutrition in terms of calcium and phosphorus intake? calcium and phosphorus supplies are absolutely necessary from the first day of life in very low birth weight infant on parenteral nutrition, firstly to reduce the incidence of hypocalcemia, but also to avoid the development of hypophosphatemia. For the calcium supply, you can provide the calcium as calcium chloride, but portion to acidosis with chloride, calcium gluconate, or calcium glycerophosphate. Unfortunately, calcium glycerophosphate is not directly available for parenteral nutrition, and you need to put the calcium glycerophosphate as a powder in the parenteral nutrition, and you cannot make any sterilization except you make sterilization by filtration. So it is not very easy to use calcium glycerophosphate in parenteral nutrition for the preterm. In fact, up to now, the phosphorus supply is frequently limited due to the risk of precipitation or due to the old recommendation to some limitation of the sodium and the potassium intake during the first day of life. As you know, it is impossible to provide presently some phosphorus without to provide, in addition, sodium as sodium salt or potassium salt in parenteral nutrition. And so there is still some unit we do not use phosphorus during the first day of life in the preterm infant. And what we know is that if you provide calcium and a relative high amino acid supply without phosphorus intake in the preterm infant, you will induce hypophosphatemia, which can be defined as a plasma concentration of 1.6 millimole per liter. Hypophosphatemia is deleterious for the preterm infant, firstly for bone metabolism, but it was also shown that it is also deleterious for acid-base status and for energy metabolism. And there is some studies suggesting that there is an increase in nosocomial infection in preterm infant with hypophosphatemia, and more recently that the increase of the incidence of hyperglycemia preterm. So what is the serum reference value for phosphorus in the preterm infant? Hypophosphatemia has been frequently observed and reported during the first week of life in very low birth weight infants, and for some, they take as reference 1.3 millimole per liter. In the adult, and if your laboratory provides the result of the adult patient, you will see that the phosphorus level, the minimal value of phosphorus is about 1 millimole in adult. So if you use adult level, most of your infant could be hypophosphatemia. And severe hypophosphatemia, as I said before, it induces higher increased incidence in sepsis, the use of vasoactive drugs, mechanical ventilation, or hyperglycemia. Recently, we have an Hippocrates lesson in Jakarta, and I was very surprised to see that they have very few use of phosphorus during parenteral nutrition, and they report me that they have several difficulties to weaning from the respirator, from the ventilation of the preterm infant due to hypophosphatemia in the preterm infants. And with Thibault-Zarter, we recently showed that if we decrease the calcium to phosphorus molar ratio in parenteral nutrition to a value 1 or below 1, or in enteral nutrition to a value below 1.3, we are allowed to avoid or reduce hypophosphatemia in the very low birth weight infant. Therefore, a serum concentration superior to 1.6 millimole per liter need to be considered as the minimum reference value during the first week of life in the preterm. And how we can define this value? We can look to the urinary threshold level of excretion of phosphorus in the preterm. And you see that if we correlate the urinary phosphorus excretion to the serum phosphorus concentration, you see that the threshold level to obtain a significant phosphorus excretion is about 5.5 milligram per deciliter, or about 1.6, 1.7 millimole per liter. And it has been also shown that the serum reference of phosphorus is not the same during all the life. They decrease slightly from an infant of 1 year up to the adult, but that is significantly higher during the first week of life in the preterm infant, confirming this value, this minimum value of 1.6 millimole per need for the preterm infant. Up to recently, in most of the parenteral nutrition solutions used by neonatologists, they use calcium phosphorus ratio, molar ratio, quite similar to what we obtain in enteral nutrition, about 1.6 millimole per millimole. With such a ratio, what they observe in the study from Chrisman from Holland, they see that there is a progressive increase in calcemia, a progressive increase in calciuria, hypophosphatemia, no phosphorus in the urine, and a progressive increase in serum alkaline phosphatase, with an increase in tubular reabsorption of phosphorus by the kidney. At that time, supply phosphorus after the first few days of life, and they observe a progressive decrease of the calcemia, increase of the calciuria, increase in phosphatemia, and increase in phosphaturia. The serum phosphatase, alkaline phosphatase decreased progressively, as well as the percentage of phosphorus reabsorption in the kidney. As they continue to provide supplementation of phosphorus in addition to our enteral nutrition, they become progressively relative phosphorus overload in that study. An additional study was presented by Brenner in 250, and they show that hypophosphatemia in preterm relatively frequently observed. They evaluate the prevalence of hypophosphatemia during the first week of life in preterm infant receiving aggressive parenteral nutrition, and they observe about 91% of the infants with hypophosphatemia. And as in the previous slide, it was the result of an imbalance between the calcium and the phosphorus, and a deficiency of phosphorus from the first day of life. In parenteral nutrition, we made some metabolic balance study using calcium glycerophosphate. So in our solution, we can provide 1.8 millimole for 100 milliliters of the parenteral solution, 2.6 grams of amino acid, and 12 grams of glucose, and there is separate addition of lipid to this parenteral solution. We see that when we look at calcium retention and phosphorus retention, we see that the ratio between the calcium phosphorus retention is 1.25 in terms of molar ratio and 1.6 in mass ratio. So if we look to the metabolic balance that we perform in enteral nutrition, we saw similar result. If we look to the ratio, the calcium phosphorus molar ratio of the calcium phosphorus retention, we see that according to the increase in calcium retention, we have an increase in this ratio, but they will never reach the bone reference due to the need of additional phosphorus for energy metabolism and cell growth in the preterm. With the solution that I presented before, you see here the evolution of the serum calcium concentration and serum phosphorus concentration. It was mainly all the time over 1.5 millimole. We look the incidence of hypophosphatemia in those infants. During the first week of life, first 3 days of life, it represents about 25% of the infant, but some have hypophosphatemia at birth. And after the first few days of life, during the second week of life, it decreased to about 11%. So decreasing the calcium phosphorus ratio to about 1 millimole per millimole, and you decrease the incidence of hypophosphatemia during the first day of life. But it is possible that in some infants, especially with intrauterine growth restriction, you need to decrease this ratio below 1.
Jacques, we are running a bit late.
I have just 5 years.
Perfect, thank you.
I don't know, I think that Walter present the recommendation from the SOCIEDAD in 2018 for the preterm infant. They suggest to start with about 1 millimole per kilobody weight per day of calcium and phosphorus, and in the growing preterm infants to go to 1.6 to 3.5. For that, it was based on the fetal accretion rate. But I have 2 remarks. That they suggest to provide calcium and phosphorus on the first day of life. But unfortunately, in the electrolyte recommendation, they say that the ratio, that the recommendation come from 0 to 1 on the first day of life. But if you provide 0 electrolytes, sodium or potassium, it is impossible to provide some phosphorus during parenteral nutrition. So there is a discrepancy in electrolyte and the mineral recommendation. By contrast, the maximum calcium and phosphorus intake that they provide, 3.5 millimole per kilo per day, but there is no study demonstrate the solubility and stability of such a concentration in parenteral solution. As well, I never see any clinical study showing the tolerance and the safety of those infants. And I do not think that it is necessary to go so high in calcium and phosphorus in parenteral nutrition. We know that in enteral nutrition, the maximum reported retention is about 2.5, 2.8 millimole per kilo per day, without evidence at that time of bone disorder. So for the survey of the calcium and phosphorus, we can look to the plasma concentration, and with a special focus to the phosphorus concentration, because the calcium concentration is a poor indicator of the intake because there is a strong metabolic homeostasis. The phosphorus concentration, I show you that they need to be higher than 1.6, and lower than 1.6 is a good indicator of phosphate deficiency of potential osteopenia. A phosphate concentration superior to 3 is a poor indicator of phosphorus overload, as the phosphorus concentration is regulated by the renal excretion. But I think that the increase in alkaline phosphatase is a sensitive indicator, and later on, a PTA. So I will stress on the urine. I think that the calcium and the urine excretion is interesting to follow the homeostasis of the calcium and phosphorus in paralateral nutrition. But I prefer to use the ratio between calcium and phosphorus and not to use, as sometimes suggested, only the calcium or the phosphorus below one level, because there's some influence of the dilution of the urine. If you use the calcium phosphorus ratio, as I show you that there is very intercalated, you can improve the sensitivity of the evaluation is higher than the absolute value, and you can test if you have for a deficiency in phosphorus or an excess in calcium in the paralateral nutrition. You can also use the tubular reabsorption of phosphorus as an indicator. When they are very high, you can be in a relative deficiency of phosphorus. And I show you now.
I'm afraid we have to cut short a bit. Huh? We are a bit too long.
Voilà, that is the last slide. Just to say that the previous recommendation are based on the fetal mineral accretion and are inadapted to their use in paralateral nutrition. The physiological change in bone metabolism with the stimulation of the remodeling process induces spontaneous reduction in bone mineral density. And the mineral balance and clinical studies suggest that the optimal calcium phosphorus ratio in paralateral nutrition is between 0.8 and 1.2, reducing the risk of hypophosphatemia in very low birth weight infant. And in practice, the mineral intake will be 1 millimole per kilobody weight during the first day, increasing to 2.5 after a few days. The last point is, do not forget vitamin D in the preterm infant during paralateral nutrition. The vitamin D support from the beta lipid, and so the lipid vitamin is relatively low and does not correct the frequent vitamin D in the preterm infant. Thank you very much for your attention.
Thank you, Jacques. Excellent talk. Sorry if I had to press you, but I mean, time is.
Yes, I know.
It's a bit of it's a limited. So, is Joe with us?
Yes. Can you hear me?
Oh, good to see you, Joe.
Yes.
May perhaps you'd like to introduce Jeffrey Segar yourself.
I would be very pleased to introduce Jeff.
Please do so.
Yes, so Jeff is a very good friend. He's a professor of pediatrics, Division of Neonatology at the Medical College of Wisconsin. He completed training in pediatrics and neonatology at Iowa, University of Iowa, where he remained on the faculty for 27 years. At Iowa, he ran an NIH-funded research laboratory for over 20 years and served as director of the Division of Neonatology for 11 years. He recently relocated to the Medical College of Wisconsin in Milwaukee in 2019, where he is currently the Associate Chair, Department of Pediatrics. In addition to extensive experience in clinical care of critically ill neonates and teaching, Dr. Segar has engaged in a breadth of basic and clinical research. Most recently, his work has focused on identification of sodium requirements in premature infants to optimize growth and neurodevelopmental outcomes. Thank you, Jeff. Take it away.
All right, Joe, thank you. I appreciate the opportunity for this presentation. So as you know, we all recognize the provision of water is really one of the most basic concepts in sustaining life. And despite the fact that really we provide this to thousands of infants who receive parenteral fluids each year, there's really very limited experimental data that we have available to us to decide about what the appropriate amount is. So for example, from the most recent Cochrane reviews, the randomized controlled trials for antenatal steroids to prevent RDS has included over 11,000 patients. In the adults, they've studied almost 100,000 patients with regards to the use of beta blockers for hypertension. But in examining water intake in premature infants, there's fewer than 1,000 patients that have been enrolled in randomized trials, again, limiting the amount of experimental information that we have. So some basic concepts in terms of understanding fluid therapy in preterm infants is we all recognize that after birth, total body water falls primarily due to contraction of the extracellular space. This degree of contraction is inversely proportional to gestational age in terms of percent birth weight, and is greater in small for gestational age infants than inappropriate for gestational age. We do not know what the optimal amount of weight loss is, although in the literature and in practice, we know that preterm infants may exhibit a weight loss of 5 to 15% during the first week of life, whereas term infants typically exhibit a little less weight loss, more in the 5% range. And as I've mentioned, the optimal amount of weight loss is unknown, although the literature would support that the failure to allow this normal postnatal contraction of the extracellular water and weight loss in preterm infants may increase the risk for morbidity. So just to review a couple of the informative trials, this is a study from almost 40 years ago. They randomized infants 750 to 1,500 grams to 2 fluid protocols. As you can see here, they started with infants between 70 and 80 milligrams per kilogram per day, or in group 2, a little bit less than that. Again, in both groups, targeting fairly significant weight loss though. In their higher fluid group, they still targeted a 10% weight loss, and in group 2, a 15% weight loss. And then they had a fairly strict protocol for how to provide fluid beyond the first days of life related to changes in urine output as well as body weight. And essentially what this study showed that there was no difference in clinical outcomes with the variation in fluid intakes, again, with targeting between 5 to 15% loss of body weight. Though I would say that this study was greatly underpowered to look at the clinical outcomes in terms of mortality rates of bronchopulmonary dysplasia and such that they looked at. Interestingly, the difference in weight loss was less than 1/5 of the difference in fluid intake. And what they demonstrated is that the water balance was really maintained by regulating urinary water excretion. And so what we learned from this, at least within a range of fluid intakes that don't overwhelm the infant's capacity to remain within a range of negative water balance, is that there's a range of acceptable fluid intake early in life, because the kidneys can, to a certain extent, regulate the concentration and thus the volume of water that's lost in urine. Here's another study, a little more contemporary, looked at 100 infants, again had what they called a dry group where they started at 50 milliliters per kilogram per day, increasing up to 120 over the first week. In their control group, they started with 80, going up to 150. As you can see, again, within both groups, there was relatively significant maximum weight loss from birth weight. And what these investigators showed, at least in their control group, which was their higher fluid group, is that death occurred substantially more often than in their low fluid intake group. Now, the vast majority of these deaths occurred within the first 4 days of life for reasons that were unclear in the publication. So I'm a little bit skeptical about these results. But again, they speak to the fact that, at least based on these data, that higher in fluid intakes can be detrimental and that low fluid regimes have a significant effect in terms of reducing morbidity and mortality. This was a pair of studies published by Cavadia in 2000, looking at 168 infants, 23 to 33 weeks gestation. Again, 2 different fluid regimens, starting at 60 to 70 mLs per kilogram per day, progressing up to 150 or 80% of this. Again, despite differences in this fluid intake, the weight changes were similar, which again suggests the ability of the preterm kidney to be able to regulate water loss by changing osmolality of urine. And again, these investigators really saw no significant difference in any of the short-term or long-term outcomes that they included. But again, relatively small number of infants, essentially a study that's really underpowered to look at any of these outcomes. And so then if we look at some additional studies that are retrospective in nature and such, we see that in this first publication by Ascoy, they looked retrospectively at a little over 100 infants. They grouped weight loss on the 3rd day by quartiles and showed that the mortality was lowest in the 2nd and 3rd quartiles, where weight loss ranged between 3.1 and 12%. So in the absence of weight loss or in the presence of extreme weight loss, mortality was higher. A couple of other retrospective large studies looking at, this is from the Neonatal Research Network, looking at, in this study, almost 1,400 infants, and in the second study, almost 10,000 infants. Again, in the study by Below, they showed that the higher fluid intake and less weight loss were again associated by death in BPD. And again, in this study, they define postnatal weight loss as any loss of weight from birth weight during the first 10 days of age. So they showed that with postnatal weight loss, there is a decreased risk of death or BPD, both for appropriately grown infants with an odds ratio of 0.47, or for small for gestational age infants with an odds ratio of 0.6. So again, collectively, these studies, though retrospective in nature, demonstrate the importance of postnatal weight loss in limiting the morbidity and mortality of infants. And that becomes a key point in the provision of fluids to infants during the first week of life, in that rather than targeting specific formulas for fluid intake, we need to be paying careful attention to what the weight loss is and using that information to help guide the amount of fluid that we provide. So when in thinking about the provision of water in the first few days of life, really the keys are to provide enough to avoid hypernatremia, but also to avoid for this weight loss that we're talking about. So a couple concepts here. Where is water lost from the infant to the external environment? Well, we know that there's loss through skin evaporation and through the lungs through evaporation. Collectively, we're referring to this as the insensible water loss. There's some water that's lost in stool that's essentially negligible, and we can essentially don't need to really account for this. And then obviously in the kidney, where we need sufficient urine production to excrete waste products. The sources of water are, there's metabolically produced water from the oxidation of carbohydrates that, again, in our calculations, we tend to ignore this, and it typically offsets the water that's lost in stool. And then obviously in the population of infants that we're talking about, the primary source of water is whatever we prescribe for that infant in the parenteral or enteral fluids. So if we take this first equation where we look at this balance between water intake and metabolically derived, and that needs to equal essentially our insensible water loss lost in the urine, fecal loss, water for growth, that again, within the first few days of life, we can essentially ignore this value. And then focusing on the desired weight loss, we essentially reduce this equation to the prescribed water intake should essentially equal insensible water loss, obligate urine requirements, and then including this negative value because we want the infant to lose water and to lose weight. So let's quickly look at what the determinants of insensible water loss are, as well as urine water requirements. This is a figure most of us will be familiar with that shows this exponential relationship between decreasing birth weight and increasing insensible water loss. This relates to a number of factors in terms of the surface area to body weight ratio, maturation of the skin blood flow, and respiratory rate. Okay. The values in this figure were derived from studies where infants were cared for under open radiant warmers. I highlight that these values are anywhere from 30 to 50% lower for infants that are cared for in a humidified incubator. I've drawn a couple lines here because we're going to use this in an example in a couple slides. And so here I've outlined that for an infant at birth who weighs about 1,000 grams, okay, and cared for in an open radiant warmer, their insensible water loss is about 4 mLs per kilo per hour, or about 100 mLs per kilogram per day. And we'll get back to that number in an example in a minute. So here's just a table that I've put together. These are estimates. These aren't necessarily derived from detailed studies, but just shows the difference in insensible water loss across a range of birth weights. And then again, the difference between infants who are cared for under radiant warmers and humidified incubators. So it's important in thinking about the fluids that we provide to infants, what the environment is that these infants are cared for. And there's a number of additional factors that I'm not going to go into that can obviously alter insensible water loss, particularly in infants that are cared for under radiant warmers, such as applying barriers and such. So if we talk quickly about what urine water requirements are. So urine is necessary for the excretion of soluble waste products. We recognize that the capacity of the neonatal kidney to concentrate solutes is limited. So for example, in preterm infants, the maximum concentration ranges between 500 and 600 milliosmoles per liter, whereas in adults, the adult kidney can concentrate urine up to 12 to even 1,500 milliosmoles per liter. Okay. If we think about the waste products or the renal solute load, it's primarily of dietary origin, related both to the nitrogen intake or protein intake and the electrolyte content. So this isn't an equation that we typically use in clinical medicine, but again, this is just to provide an understanding of where we derive ultimately the amount of fluid that we think infants need. Okay. So here we can see that a gram of protein provides essentially 5.7 milliosmoles of urea that needs to be excreted. So if we go back to this 1,000-gram infant who in the first day of life is only going to receive crystalloid fluids with the minimum electrolytes of 2 milliequivalents per kilogram of sodium chloride. Again, this is just an example. This infant therefore needs to excrete 4 milliosmoles per kilogram of the sodium, and then 6 milliosmoles for urea and catabolism, essentially 10 milliosmoles per kilogram, is then for this infant to excrete that with a urine osmolality of 300, which is relatively dilute. This infant would need to make about 34 milliliters of urine over 24 hours, or essentially about 1.5 mLs per kilogram per hour. Obviously, this infant could excrete this solute in less urine by generating urine that has a higher osmolality, which it should be capable of. So again, if we get back to this 1,000-gram infant cared for again on an open warmer bed, we go back to our equation. Remember in this instance, our insensible water loss, we estimated at 100 mLs per kilogram per day. We've estimated that the infant needs to make about 34 milliliters of water to excrete the solute load that we've given him or her. And then accounting for about a 2% weight loss over 24 hours. So we subtract 20 mLs. We come up with an estimate of about 114 mLs per kilogram over the first 24 hours. Now, if this infant were receiving venous nutrition in the first 24 hours, which I would encourage everyone to provide, there's obviously a greater solute load that this infant would need to excrete based upon nitrogen. And in this case, then the infant would need to make a little bit more urine. In this case, about 53 mLs per kilogram, again, to excrete the solute load with a urine concentration of 300 milliosmoles. Okay. So necessary water intake is increased if receiving parenteral nutrition, and certainly decreased if cared for in a humidified incubator. So really the principles that are important in providing water in the first few days of life are really dependent upon the infant's gestational age, weight, condition of the skin, whether the infant received antenatal steroids, the housing environment. We've talked about incubators versus open warmers, the degree of respiratory support, since an infant that's on humidified air is obviously going to have less insensible loss through the respiratory tree, and then nutritional intake and the solute load. It's really important to individualize to the degree possible and to assess and reassess using an infant's fluid balance, their change in their weight, and then their serum sodium or chloride. Again, we don't know what the optimal amount of weight loss is for outcomes, though the data are fairly reasonable to suggest that we should be targeting between a 5 to 15% weight loss over the first few days of life. And then it's important to avoid hypernatremia. So this is just a chart that I've put together that again gives some estimates on starting fluids for, again, infants that are cared for on warmer beds. I've provided the total amount of fluid here. The way that I prefer to do this clinically is to use a 2-solution process. One solution is venous nutrition that provides anywhere from probably 25 to 50% of the necessary fluid. The idea is to provide some protein and to provide some parenteral nutrition. And as we adjust the infant's fluids over the first few days of life, we don't have to adjust this. What we can adjust is this additional fluid that ranges from a D2.5 in the most preterm infants to D10. So this ensures that we don't have a period of time where we have to stop our parenteral nutrition and stop the provision of protein. Again, it's important to follow daily weights and to follow serum electrolytes at time points that again vary depending upon how premature the infant is and how critically ill they are. So beyond the first few days of life, we know that insensible water loss decreases with skin maturation. Urine output increases as solute load increases, as additional nutrition is provided. IV rate can be adjusted again based upon factors that we've talked about. For infants less than 1,000 gram, fluid requirements typically decrease over the first few days of life as insensible water loss decreases dramatically. And for infants less than 1,000 grams, typically it increases so that we're able to provide the nutrition that we want these infants to receive. And again, it's important to remember that the kidney is capable of handling a range of water intake by adjusting urine osmolality, and this ability increases with postnatal maturation. So one last talk. This is really probably the best known paper related to fluid therapy in premature infants, published by Ed Bell in New England Journal in 1980. They actually prescribed fluid therapy over the first month of life and generated their limits focusing on urine volume, including stool loss, insensible water loss, and accounting for water for growth. This study endpoint was patent ductus arteriosus with congestive heart failure. Again, these infants are relatively old. You can see the difference in fluid intake. This is average fluid intake daily over the first month of life. Initial percent water loss, weight loss was similar. But as you can see, those infants that received the higher fluid intakes had significantly greater rates of PDA with congestive heart failure, PDA in general, and actually higher rates of necrotizing enterocolitis. The bottom line of this is too much fluid is bad, but again, it really doesn't tell us what the optimum amount of fluid is. So let's talk sodium quickly. This is one of the earlier trials looking at infants 24 to 30 weeks gestation. These infants were put on a sodium intake of 4 milliequivalents per kilogram per day, beginning on day of life 2, or not until there is a weight loss of 6% from birth weight. Okay. These two populations of infants, fluid intake was similar over the first week of life, as well as energy intake similar. But what they did show was that delaying the sodium supplementation was associated with decreased duration of the need for supplemental oxygen. So here you can see that the study group, which was the two different sodium intakes, is those infants that were in the low sodium group had significantly decreased duration need for supplemental oxygen. This is a very small study. As you can see, they look only 8 or 9 infants in each group. You can see what their sodium supplementations were different. So essentially in the maintenance group, they received about 4 to 5 milliequivalents per kilogram per day of sodium over the first 5 days of life, whereas the restricted group received essentially about 1 milliequivalent per kilogram per day. Sodium output in the urines were similar. And here's the sodium balance. And again, although these numbers are very small, as you can see that the rate of BPD was essentially half in those infants that received the restricted sodium intake. So a very small sample size to make conclusions about, but again, it argues that restricting sodium in the first few days of life is of benefit. So essentially during the initial first few days after birth, contraction of the extracellular fluid compartment is manifested by natriuresis and diuresis, and that a negative sodium balance is achieved during this time by obligate renal sodium losses related to kidney tubular immaturity and the importance of limiting parenteral and enteral intake of sodium. So essentially from a physiologic standpoint, there's really no reason to provide sodium within the first couple days of life. Clinically, we all recognize that this is difficult to do, but again, from a physiologic standpoint, restricting sodium intake and allowing that contraction of the extracellular water space and weight loss is important. So beyond the first few days of life, a positive sodium balance is necessary for growth. On average, a neonate would accumulate about 1.4 millimoles for a 30-gram increase in lean mass. So this is essentially the calculation that goes into that. A 30-gram increase in weight, typically about 70% of weight is water. 50% of this water is going to be the extracellular water, which on average is going to have a sodium concentration of about 140 millimoles per liter. So within this extracellular water, we have about 1.4 millimoles per sodium. So again, infants need to be in a positive sodium balance to allow for growth, and really identifying the sodium requirements requires an understanding of sodium losses, and particularly obligate urine sodium losses. So this is a figure I generated a couple years ago. On top, this is urine sodium concentrations over a range of gestational ages and across with postnatal maturation. The figure on the bottom is total urine sodium lost. And so these are generated data that were from the literature that have subsequently been validated in studies. And what I really want to focus on is looking at urine sodium loss. So you can see over this range of gestational age, you can see that there's really large amounts of sodium that are lost in the urine, really out to 6 weeks of age. I've drawn a line here at 5 milliequivalents per kilogram, which is the maximum that's recommended for preterm infants by the AAP or ESPGHAN during stable growth phases. And so you can see that the provision of this amount of sodium is really insufficient during this period of life for infants with this degree of prematurity. And again, this doesn't take account the need for the additional sodium to provide for growth. This is a study, this is actually done in rat. I think this is for illustrative purposes. So this is a study that was done in weaning rats. They gave rats from 3 to 8 weeks of age sodium intakes that have a 30-fold different range in intake. As you can see, that those rats that received the lowest amounts of sodium failed to grow well, failed to accumulate nitrogen, had similar body water, and importantly, their serum sodium is the same. And I bring this up because this is an important point, is that clinically, we cannot use serum sodiums to identify sodium depletion. And I would argue that in the face of hyponatremia, that is consistent with total body sodium depletion. However, serum sodium values that are in the normal range don't rule out that an infant isn't sodium depleted and isn't receiving the amount of sodium that they may need for optimal growth. So here's a study done in 2016. This group randomized infants less than 32 weeks of gestational age to either sodium supplementation of 4 milliequivalents per kilogram per day above that typically provided in their diet, or placebo. Gave this over the 1st to the 5th week of life and showed that those infants who received the sodium supplementation, the vast majority of those infants maintained their birth percentile at 6 weeks, whereas those that were on the placebo had significant postnatal growth failure. There was a slight but non-significant difference in length as well, and no difference in head circumference. So as I mentioned, hyponatremia is a marker of total body sodium depletion, and studies have shown that it's a risk factor for morbidity related to hearing loss, cerebral palsy, worse neurodevelopmental impairment, and risk for bronchopulmonary dysplasia. And so from a clinical aspect, I believe that the current recommendations for sodium intake are likely insufficient for many preterm infants for optimal growth, and that these current recommendations fail to take into account the degree of renal immaturity that's present in extremely preterm infants who are now surviving after birth. And it's important to note that sodium supplementation or the provision of adequate amount of sodium isn't promoting growth, but rather it's sodium deficiency that's impairing growth. So here are the recommendations that I've put forth, and these have been shared by some others as well, that shows that really in these most preterm infants at 22 to 28 weeks gestation, is there's really sodium supplementation that's required during this important growth phase that's really beyond what at least exists in the literature in terms of the recommendations and such. And although it's not ideal for infants who aren't growing well, one thing that I've advocated is obtaining a urine sodium concentration in infants who aren't on diuretics to identify infants who are sodium depleted. And the literature would support that a urine sodium concentration in these infants that's less than 30 to 40 millimoles per liter would identify infants who are likely sodium depleted and certainly may benefit from a growth standpoint in terms of providing additional sodium. One slide on potassium. We know that preterm infants are at risk for non-oliguric hyperkalemia. This is related to decreased activity of the sodium potassium ATPase, as well as a lower glomerular filtration rate. We know that this risk is reduced by exposure to antenatal steroids, as well as the early provision of amino acids. After allowing this postnatal contraction of the extracellular space, and diuresis has developed, as well as an adequate urine output, typically once the plasma potassium levels are below 4 to 4.5 millimoles per liter, it's reasonable then to provide potassium intakes of between 2 to 4 millimoles per kilogram per day. And this is usually sufficient to maintain normal plasma potassium, as well as for allowing for growth. So I'll end it there. And again, thank you for the opportunity to share with you this information.
So thank you, Jeff and Jacques. I think that this is wonderful. Both lectures I really enjoyed, and very informative. Learned a lot. So maybe we can start. Virgilio, do you have some comments or questions?
I think we have several questions in the Q&R sessions. I think this question should be visible to speakers, right? So maybe we can group them, group the few, and see. I would start from the question on calcium phosphorus, and there are a few questions concerning the ideal calcium phosphorus in parental nutrition, but I think Jacques they give already an answer for that. There are a couple of questions on stability data. Jacques, is there solid data for this low ratio 0.8 calcium to phosphorus? Probably some people in the audience want to be reassured this 0.8 ratio is sort of supported by good stability data. Can you comment on that? Your mic is, you're muted, Jacques.
I want to say that I start to answer directly to the question, but now they disappear from my computer, so I will not continue to answer. But for the calcium phosphorus ratio, a calcium phosphorus ratio of 1 to 1 is relatively stable when you have an amino acid content of more than 1%, 2%, and when with a pH of the solution which is relatively acidic. The problem is that you need to test the stability, because it depends on the calcium salt or the phosphorus salt. If you use calcium chloride instead of calcium gluconate, and so it is difficult to answer individually when we have not the full composition of the parenteral solution.
There's an interesting question. Somebody is interested in whether sunlight, exposing baby to sunlight in the NICU would have an impact on vitamin D metabolism. It's a bit, but perhaps you can also answer the question whether, there are a couple of questions, whether SGA babies may have a different requirement, I assume, compared to AGA from calcium and phosphorus. Whether you have some comment on SGA baby next to the sunlight in the NICU.
I mean, for the sunlight, it is easy to answer. I never see any neonatal unit when you put the baby outside of the unit in the park at 1,000 grams in order to provide sunlight, and I will not be in favor. I think that it is preferable to provide some additional vitamin D, but I think that it is very important actually to to measure the vitamin D of the preterm infant as soon as possible after birth, to know if they are vitamin D deficient or not. I think that the problem could be significantly different in the US as in Europe, because in the US we have quite a lot of supplementation of vitamin D for the mother and in the diet. And so I remember that we make some study suggesting that the bone mineral content of the newborn infants in US at the same body weight was higher than that in Europe. So it is probably a difference in vitamin D. But in Belgium, in France, 90% of the mother are vitamin D deficient at the time of birth. So it is important to measure and to correct as soon as possible the vitamin D level of those infants.
What about SGA?
For the preterm infant SGA, you need to make caution with the phosphorus, because sometimes at birth they are phosphorus deficient. So you need to provide additional phosphorus to those preterm infants very quickly during the first day of life. And sometimes to provide a higher level of phosphorus that in appropriate for gestational age infants.
Okay, thank you very much. There is probably one last interest. I made a bit of selection because we are running behind time. There are a couple of questions on oral phosphorus supplementation. What you think about giving oral phosphorus, to supplement hypophosphatemia in preterm infant.
But I think that if you have hypophosphatemia in the preterm infants on enteral nutrition, you can provide some additional phosphorus. That is not very complicated to provide additional phosphorus. I am not in favor to manipulate too much the formula, because you can destabilize the formula if some precipitation too, and it is quite difficult to see the precipitation in the formula. The formula are sometimes very sensitive to for the stability of calcium and phosphorus, and I remember that in order to facilitate the dilution and the reconstitution of the formula, one company modified the technique and the composition of his formula, and he said we have exactly the same calcium and phosphorus content, but we observed some hypophosphatemia in that, and it was just the technology of the preparation. So it is true that the stability of calcium and phosphorus, even in the formula, need to be considered at additional supplementation could induce some destabilization of the calcium and phosphorus content. So we need to make caution of that.
Thank you, Jacques. I think we can move to the, there are a few questions on the fluids and electrolytes. Perhaps I can pose it 2 or 3 and then you go on. Fluiding, there's an interesting fluid balance or intake in BPD infants. There's a question whether we should use birth weight or daily weight to calculate water intakes. And another interesting question is the management of polyuria or increased diuresis in the first day of life. And there's a bit of an experience here of giving high, 1.5 millimole sodium in the early days of life, but perhaps we can return on this. So these are some starting points. Perhaps, Joe, you can continue on that. So fluid intake in BPD, or in infant development BPD.
Infant BPD.
Please share your thought with us.
Yeah, my thoughts for infants with BPD are to use high caloric density feedings, to limit fluid intake as much as possible, and to avoid diuretics.
I agree totally. Fantastic. It's also what I'm trying to do. Avoid diuretics, which are very bad.
Yeah.
talk to my colleague and my junior doctor. Restrict the fluid. Don't give to. Don't you know, prescribe diuretics. I mean, when possible.
Yeah.
Great.
With regards to what weight to use, is probably in the first 5 to 7 days of life, I prefer to base calculations based upon birth weight rather than the daily weights, because it provides a fixed point of reference. And so when, and obviously, you know, it probably clinically doesn't make a huge difference which one you use. Again, recognizing what your goals are, which is to, you know, lose 2 to 3% of birth weight over the first few days of life. And again, avoiding either hyponatremia or hypernatremia. With regards to the sodium intake, you know, probably 1 to 2 milliequivalents per kilogram per day in the first couple of days doesn't make a tremendous difference. You know, we know clinically it's very difficult to avoid sodium intake in the first few days of life. Something needs to be in those fluids and such. What we really want to do is avoid giving large amounts of sodium within the first few days of life. And there's some studies up there that have demonstrated that, you know, there can be a lot of sodium intake in the first few days of life, really up to 8 to 10 milliequivalents per kilogram per day if you're not paying careful attention to what you're giving these babies. So that's the key point, is to just limit the intake as much as reasonably possible, recognizing that we still want to provide some nutrition and such for these babies.
Joe, did you pick up other interesting questions?
Yes, there's one here that I think is kind of interesting and maybe somewhat complicated, but I like this question. Doesn't the sodium the baby can have during the first 2 days of life also depend on the amount of amino acids you provide during these days? We provide 1.5 to 2.5 grams of amino acid on days 1 and 2 of life in combination with plus or minus 1.5 millimoles of sodium per kilo per day. We do not see frequent hypernatremia. This way, the baby also gets phosphate.
Yeah. And so again, you know, I think this relates to my comment that, you know, it's difficult to completely avoid sodium intake in the first few days of life, because we do want to provide some nutrition, and I certainly agree with giving some phosphate in the first few days of life. So again, the focus is limiting the sodium intake as much as possible, and just being cognizant of providing an inadvertent amount of sodium. But I'm certainly, although I am not a nutrition expert, I am certainly in favor of providing amino acids and phosphate in the first 24 hours of life.
This is probably, if you could share your thought, I think we're running out of time, on management of polyuria in the first day of life, increased diuresis. What are your thoughts about this? Yeah,
I mean, some premature infants just excrete large amounts of urine. They filter, but they don't reabsorb water. They typically don't reabsorb electrolytes. So these are infants that require frequent monitoring of both their serum electrolytes, and I actually will on occasion monitor their urine electrolytes so that I can get a better idea of what their replacement needs actually are. And so these are infants that you know, need to have their fluids adjusted often every 4 to 6 hours based upon how much urine they're making. Sometimes this occurs with polyuric acute kidney injury for reasons that may have, you know, been related to something that occurs in utero. And again, some infants just postnatally just have you know, a large diuresis with kidneys that for various reasons really don't reabsorb water or electrolytes.
Thank you.
So there are so many excellent comments and questions here. Unfortunately, I think we're going to have to close very soon here. I'm hoping that These lectures will be available for the participants later, and that there may be some opportunities for the speakers to also answer some of these questions for the participants as we move forward. Thank you very much, Jacques and Jeff. So I think we're going to have to close, unfortunately.
Yes, this is a
Delia?
clear signal. I would like to thank you that we have to close. I would like to thank you very much again, both speakers, for their excellent talk. And then our next appointment will be on September the 6th.